So this is hemolytic uremic syndromes. So it's called syndromes because there are many different causes for it. And it comprises three important things. Kidney failure, sudden onset kidney failure in someone who's previously well. A special form of anemia, which is, this term refers to a mechanical breakup of red blood cells, and low platelets, which are important in the blood clotting system. And there are many different causes for it. Now, I came to Birmingham Children's in 1988, my job was to analyse this survey, which was of HUS, conducted in the UK over a 3-year period. Now, we didn't get all the HUS in the UK. We tried, but we didn't get all of them, but we got many of them. So you can see that there were nearly 300 children who had HUS and who had a diarrheal illness that provoked it. Now, this talk is not interested in that group. It's interested in the atypical patients who had no diarrheal illness. And you can see that their numbers are very small. So a very rare disease occurring very infrequently across the UK. And what you can see is that if you follow these patients up for 4 months or more, the long-term serious outcomes for these patients is much greater than it would be for those who had the diarrheal illness. So this is a rare disease, and it has serious long-term outcomes, including a significantly higher incidence of death proportionately. So here is a case that presented to us back in 1989, so when I was soon after I arrived. This was a boy of 3 months that was transferred to us from a local hospital, and he presented with kidney failure. He had anemia and low platelets, so it looked like this was HUS. He had no illness, no prior illness of diarrhea, and we quickly uncovered that he'd had a brother who died some years before, who all his mother could remember was that he had kidney failure, but there was no diagnosis for why he had the kidney failure and why he died. So we dug out the post-mortem material and went back to the kidneys, and there was evidence to suggest that he had hemolytic uremic syndrome. So we very quickly realized this was familial. This was something that had happened in somebody else in the family, and it was clearly not, because of the big time difference, it was not an infectious cause, it was something else. And in those days, we didn't really have very many good treatments, and so we started him by whole blood exchanges. He'd come in about once a week. We'd change all his blood, give him somebody else's blood, and send him off and do that every week, and that was quite a struggle in somebody of his age. And then eventually he was big enough to move on to something called plasma exchange, which is where you just remove the sort of the runny part of the blood and replace that, and he went on to regular plasma exchange. Despite that, his kidney function deteriorated, and he went on to hemodialysis. At about 5 years of age, he had a kidney transplant from a deceased donor, but sadly that graft was lost quite quickly. And we were initially worried that maybe the HUS had come back, but when we looked at that under the microscope, that wasn't the case, but sadly, as I said, he lost it. 4 years later, he was found to have a genetic abnormality, and he was actually one of 2 families described by Tim Goodship and his workers when they first discussed and first identified abnormalities in this complement system that leads to the development of HUS. He eventually was transferred to the adults when he was about 16 or 17 years of age. We'd hemodialysed him for many years. We'd celebrated his 1,000th hemodialysis session quite a long time before he left. We didn't retransplant him because at that time there were no very good treatments. He had a liver and kidney transplant when he was 23 years old, and it was a very difficult time, and he sadly died following that operation. So this highlights the complexity and the seriousness of the condition we're talking about. So what we now know is that for many patients with atypical HUS, they have an abnormality of what's known as the complement system. And the complement system is one of the most important systems we have. We as a species would not be here if we didn't have the complement system, because complement allows us to defeat bacterial infection. And of course, bacteria were here before us, and so we had to have a mechanism that defended us from bacteria. And this is a system that many, many different organisms share to varying degrees of complexity. But essentially, it's a system using various pathways that recognizes bacteria, allows white blood cells to gobble them up and get rid of them, or you can put a chemical pore into the bacterial wall, and it just fills up with water and then it bursts. And also the complement system provokes inflammation, which is the repair mechanism that we use for injury. Now, it's actually a very complicated system, and this just shows you some of the components of the complement system, and I don't really want you to worry about it. But what it shows is that there are important regulatory steps. So this is a very, very powerful mechanism that exists within us. It's there for fighting infection, but it has to be controlled. If it's not controlled, you get injury. And there are many control mechanisms that operate to keep this very powerful chemical system under control. And we now know that, I showed you that our patient had factor H as a mutation. This is a French study from a large number of patients who were looked at. And what they found was that in about 2/3, various elements of the complement regulatory system were abnormal and not functioning properly because of a genetic abnormality. And these are quite serious, because here you see this particular one with factor H, within a very short space of time, in months, you're getting nearly 80% of individuals have lost their kidney function. And these are other mutations in the complement pathway, and they all show that in time, in a relatively short time, 50% or more of individuals will lose their kidneys. And the problem with this disease is that it can come back in a transplanted kidney. And although this is a kidney condition I'm talking about, actually it may affect other parts of the body. So, and you'll see in this study that 2/3 of the patients studied were found to have an identified genetic abnormality. We rather think that means that the other third, other genetic abnormalities are yet to be found. And where there were families, you can see that in familial cases, 3/4 of them were found to have complement abnormalities. So the treatments that we had previously, we used a whole hodgepodge of things, blunderbuss treatment like steroids and chemotherapy, very non-directional, just blast everything. People used to remove both kidneys. We used to do plasma exchanges and plasma infusions. We have done, in one patient, a liver transplant, and in one patient, a liver and kidney transplant, and I'm pleased to say both those patients have done very well, but clearly a major undertaking. Kidney transplants, isolated kidney transplants were done for people who had kidney failure, but there was a very high recurrence rate, and 80 to 90% of those transplants could be lost. So none of these treatments were very effective. And the treatment that's made a big difference is this drug, eculizumab, the trade name is Solaris, which acts to put a brake on the complement system. So here you see the different pathways coming down, and it acts to put a brake on the complement system and stops the complement system running in an unregulated way and causing extensive damage, particularly to kidneys. And this treatment is very effective and works very well in this group of patients. So now, in contrast to the boy that I told you about, this is a 5-year-old lad who presented to us in 2013. He had fairly non-specific symptoms, but he clearly had evidence of HUS with kidney injury, low platelets, abnormalities in the urine, and he was admitted, and because of the likelihood that he had an atypical form of HUS, we started plasma exchange. When I spoke to the mother, it was evident that there was a family history, because she told me, oh yes, I've heard all about this condition. His brother had this 5 years ago, which was a big surprise to me, because I didn't know about this brother. Normally we know all about the patients who have these diagnoses, but for various reasons, the brother had not been followed up. He was actually very well, but clearly this was familial. And so he was diagnosed as having familial HUS, and we went on to manage him with the plasma exchange and eculizumab, because we thought it's likely there's a complement abnormality, and sure enough, complement test, genetic testing showed that he did have a mutation in one of the complement regulatory genes. So it all fitted. And interestingly, the same abnormality has been found in his brother, who has never, ever had this disease again. But he's still got the same abnormality, so that's a conundrum. And this just shows you his clinical course. So if we look at creatinine, which is a waste product produced in the body, which the kidneys get rid of, the green zone is the normal range. He came in with a very high creatinine. We treated him, it came down to normal. Because this is a relatively mild mutation, I tried stopping the eculizumab, and you can see within some months he had recurrence, the disease came back, and I think, in fact, Larissa, you treated him when he came in, didn't you? And we started the eculizumab again, and you can see the creatinine returned completely to normal again. Effectively, he's been cured at that point. And this is LDH, which is an enzyme found inside red blood cells, and it tells you something about how rapidly the red blood cells are breaking down. Here's the green zone, the normal range. He came in with a level very, very high, rapidly normalizes, stopped the eculizumab, and you can see again, this mirrors the creatinine. This was a relapse of his disease, and it became controlled very, very rapidly. What a contrast for the first case that I showed you, and this boy is very well. He comes in every 3 weeks to have the drug, and he goes off and he spends just a few hours with us to have the treatment. Totally different clinical course. So what I've told you is that this is a rare but very serious kidney condition. In most cases, we now know that there is a genetic abnormality which leads to dysregulation of the complement system. The majority of the abnormalities that we see are causing a problem with regulation of this very powerful complement system, and this new drug has brought about a situation in which we can control that very effectively. The drawback, as with many drugs for rare diseases, is that it's very costly. There presently is a national scheme for approval of the drug. That works extremely well. I was at a meeting in Europe last week, and many other countries wish they had the same sort of national regulatory system that we have, because it makes approval so much more straightforward. But it works very well, and it's an excellent example of a disease for the treatment of a rare, it's a drug for treatment of a rare disease that's proved to be very effective. Thank you.
Thanks so much, David. It's fantastic to hear a bit more about a treatment that's actually been developed and moving through to treat rare disease patients.